So yeah, I am a physical therapist and an athletic trainer. I wear several hats. My primary hat is I teach in a DPT curriculum. I also see patients a couple days a week, and then I do research, and my primary research is anything related to the hip and return to sport decision making. So it's pretty much me in a very brief nutshell. So can I go ahead and share? Let's go ahead and get started then. All right, so just the topic I kind of chose was kind of return to sport decision making as far as post-surgical, and just kind of the title of It's Complicated. Part of this came from some work that we've done and some work that we've published, and so I've been fortunate to publish in this area a little bit, and some of it has been frustrating looking at other studies, and so I'll kind of get into that. But I think part of the frustration too is just kind of, I think we all know, well, Adrian Peterson versus Derrick Rose, and two elite level athletes, and just all the pieces that go into making decisions and returning to sport, and how, if you were a PT at the time that Adrian Peterson came back post ACL, I mean, he pretty much made it terrible for us PTs, because like he just blew through rehab, and obviously Derrick Rose was a quite different story. So I think we need to kind of start with what is the definition of return to sport. And so I mean, this is something that Claire Arden and colleagues came in. This is how they define return to sport, and I'm not going to go through it, but essentially they break it up into return to participation versus sport. Means they may be getting at that same level, but not necessarily performing at their desired performance level. And then returning to performance is they're actually performing at the level that they were before. Yeah, but I'm going to ask several questions here, because I have several that I need answers to, I think. But so why is this messy? Well, kind of if you look in the green here, I think why this is messy is some athletes tend to be fine with going back to sport and not being at the same level. I'll talk about this a little bit later, but if you look at satisfaction scores don't always match return to sport rates. What I mean by that is, and there's been several studies out of Denmark looking at, and especially in hip arthroscopy, is people that go back to sport don't go back to the same level that they were before, but they're satisfied. So it's like, I'm just not sure why something like that. I mean, that's why they had the surgery in the first place. And return to performance is, are they performing at or above their pre-injury level, which typically we've done studies and we've always asked them, why do you want surgery? And it's almost always this, getting to that and or relieving pain. So do they really do that statistically though? And then why are some of these things complicated? And so this is the START tool that Creighton published initially, and then Ian Schreier published a little bit later. And there's a lot of things on here. And if you look at Derrick Rose, potential contract issues, going to a different team, like there's so many variables with return to sport decision making that's out of direct control of the person doing their rehab, and sometimes even out of the control of the athlete themselves. So these are all things that we need to be considerate of. And then, question is we always need to ask is, well, are we successful with doing return to sport? And well, I think that depends on what is your definition of successful, because this is a study we published in 2018, and it was a meta-analysis, and what we found is that this is post-hip arthroscopy. So we had 35 studies, over 3,000 subjects, and we found that 74% of those individuals returned back to sport. So 3 out of 4 returned back to sport. The messiness and where I started getting frustrated with this is we had no idea if they went back to the same level, because the definition of return to sport across the board and in many studies is variable. I mean, some people talked about, they were on the roster. They were, I mean, it's simple, some things as simple as that. It doesn't necessarily measure performance, and it definitely doesn't measure statistical performance. If you look at non-surgical, you look at adductor-related pain. So some of my PhD supervisors have done some work here and shown anywhere between 75 to 93% of people with adductor-related pain with treated non-surgically will go back to sport. If you look at Achilles tendon tears, again, you're kind of in that same 70 to 75% of people that have a surgical reconstruction that are at an elite level, NBA and NFL players go back to sport. So 3 out of 4. And then if you look at microfractures, so things for articular cartilage, some procedures are better than others, but across the board, it's right at this 75%. And it's about 9 months. And typically microfracture tends to drop that down quite a bit. So, then the question is, well, again, are they going back to the same level? And so this is some more work published by Claire Arden, and she showed in a series of studies that 65% of these people post ACL went back to sport, but only 55% of them went back to competitive sports, meaning, high school, college, and or whatever. But some of that's complicated too, because, perhaps they're a senior, they tore their ACL and they're not going to college. So that kind of complicates the issue as well. And this was a study that we published on Tommy John surgery. And you can just kind of look at the rates here. It's anywhere from the major leagues to high school, and these are the return to sport rates. And this is where this study is where we really got frustrated, because what we tried to do in this study is discriminate and pull out what is their performance after they go back to sport. And the nice thing about baseball is there's a ton of performance metrics, and ERA, WHIP, all kinds of things. And even with that, it was very hard to determine how many people went back to sport. So these were the return to sport rates at the same level, but the number of studies were about half of the total included studies, because the majority of these studies didn't report that. And so that complicates and muddies the waters, and you don't really know if they go back to the same level of performance, because typically this is why they want to go and have the surgery. And so the reason this is messy and challenging is these are things that we talk to our patients about, and we can't give them good information or complete information if we don't have all the results. And if we go back to that study that we published on hip arthroscopy, so 74% went back to sport. We don't know how many went back to the same level, so only 3 out of 4 actually went back to the sport that they were participating in after hip arthroscopy. And this really nice study out of Denmark. And what they did is they broke it down even deeper. So this was actually a data collection study. And what they looked at is how many went back to sport. Their numbers were about the same as ours, but then they broke it down. Okay, how many went back to the same level? So if they were on AA baseball, they don't have that in Denmark. So AA European soccer, they go back to AA. And so 57% of those individuals went back to the same level of sport that they had prior to surgery. So every other person would go back to the same level. But then when they broke it down even deeper, how many went back to the same level were performing like they were prior to surgery and were satisfied with their performance? That was 17%. So essentially right at 2 out of 10. I mean, if you look at all the studies, the surgical indication studies on why people have these types of surgeries, the athletes, it's either the primary reason is to go back to performing at the level they were prior. The second one is to get rid of their pain. But later on, I've already teased a little bit, but we'll talk about this later, is so the majority in these studies have to, well, in this case, majority don't. Then even in this study, the satisfaction rates were 40 to 50%. Like, why are they satisfied when they're not going back to the same level? And this was a study by Joshua Harris out of Houston. And they looked at, okay, if we follow them out in their performance over a period of time, so NFL, all the pro sports, and we compare them to controls, so age matched and number of years participating matched controls, the ones that really do the poorest is in NHL. There's a little bit of bias here because the studies, the power is probably a little bit off, but overall, these people don't go back to the same level of performance, and they don't perform at the same level as their cohorts that are in age match controls. And other people, Claire Arden has found this in the ACLs, and other people have found this in other performance metrics and issues as well. So again, is why are these people satisfied? And we tried to do a study where we tried to collect data on people prior going to surgery, and we tried to implement a conservative treatment program for people with hip arthroscopy. And the 9.5 out of 10 of our patients had multiple episodes of PT. They had 3 to 4 episodes of PT. They had pain for 2 to 3 years. They did not want to undergo another trial of PT, and they wanted surgery, and they expected to go back to the same level. Yet when they got done and they weren't at the same level, the majority of them were still satisfied. So why is that? What is complicated? So it's complicated because there's multiple things that you're measuring here. It's like I talked about the high school senior, and what we found in a baseball, what got very confusing with baseball is, you got AAA, AA, and single A, then you got the show. And what if somebody has surgery and was going to move down to AA anyway? And so, or they go to a different team, or they're playing football, and they have a new coach. They're in a different type of offense. So there's just so many complicating things to try to truly measure how well these people are doing after an intervention. And in this case, primarily talking about surgery, but it's not just the surgery and the rehab. So when you are doing testing, what is the purpose of testing? Is it to measure capacity? Is it to measure performance? Is it to get satisfaction? I mean, ultimately, I think we all would agree that the primary purpose initially is to determine if they're safe to go back to sport. And so, well, is that working? So what are the re-injury rates? And we'll primarily focus on ACL because that's where the majority of studies are. And so this was a really nice study by Wiggins, has been hugely cited, and pretty much just talks about the younger you are and the more likely you return to sport, the more likely you are to re-injure your knee, and which probably most likely going to be the other knee. And this was a study from the Moon group, which is a big group that looks at primarily ACLs. And these were people that had a subsequent ACL tear surgery at anywhere between time of initial surgery and 6 years. And the overall rate was 20%. So very similar to the Wiggins study. And what they found is there's more statistically prevalent in the non-surgical, so the contralateral leg. And then this was a very interesting Italian study where these numbers are way higher than most people, but it's interesting nonetheless. Is they found that the second injury for an ACL could be as high as 40%, meaning instead of the 20% with 20 or 30% with the previous studies, it could be as high as 40%. And there was a twofold risk of tearing the non-surgical leg versus re-tearing the same surgical leg. So are we rehabbing these people back to their level? Are they truly functioning off of that injured leg? Or they, why are they tearing their other leg? Are they putting excessive load on it? What are the reasons? And I think we're all familiar with this literature, and this is just one study from Mark Paterno, but the rates of a second ACL for females is much higher, 6 times higher to be compared to males if they injure the contralateral knee. And so the question is, well, are we truly preventing these? And I think we all agree that prevention is probably not the right word and probably not what we're getting accomplished. So then are we predicting, so when we're doing this testing, are we predicting who will get hurt. If you talk to people like Roald Barr and those kinds of individuals, he would say this would never happen. And then, so then the next question is, well, are we determining an association? Meaning, is there an association between performance on return to sport testing and a risk of a second ACL, whether it's ipsilateral and or contralateral? And that's a big question. And so 2 years ago, we tried to tackle this, and we published a study in JOSPT. Tim Hewitt published a similar study, and his numbers were quite a bit different than ours, but both of them came across, both of them found that passing or failing return to sport testing did not show an association with the risk of a second ACL. And I know some are familiar with a couple of studies that are out there talking about 84% and that kind of stuff, but we did not find that by passing and or failing return to sport testing that had an association on whether somebody re-injured that same knee and or the other knee. And that's kind of frustrating, because if you have somebody undergo a test battery, what our study found is that doesn't necessarily tell you and give you clearance that they're going to be okay. But part of it is that, there's so many uncontrollable things. So the next question is, well, okay, maybe it's the things that we're testing. So what are we testing? And, hop testing is primarily published in multiple studies. But if you really, so is hop testing enough? Well, then I would argue that's not even being done. And so this is a nice study by Greenberg. They just showed that, these were orthopedic certified PTs that only 55% of them only use time as a return to sport criteria post ACL. We published with Sierra Berge, we published a similar study, found essentially the same thing. And then Elliott published another study looking at people in the PRISM Society, which is a group that looks at pediatric ACLs. And even those individuals did not do return to sport test battery, or the majority of them. They primarily look at time. And even if you look at hop testing, and I am a fan of hop testing, but it has significant issues. And so there's been several studies, and I'm just going to cite two. These are two studies by Eric Hagedis that show that hop testing does not have criterion validity or contract validity. And those are things that you have to determine whether return to sport testing is appropriate. And even more disappointing is it doesn't really necessarily have very good reliability, agreement, or even responsiveness. And then there's been several studies, and this is just one. This is the most recent one that showed that sometimes people actually do hop the same distance. So essentially hop testing is taking off on one leg, landing on the same leg, and then you compare injured leg to non-injured leg and get a percentage. In this study, and this is just one of 2 or 3 studies that have shown this, in this particular study, they showed that people were able to hop the same distance on their injured leg as their non-injured leg, but how they did it is they landed with less knee flexion extensor moment, and they used much more hip extensor moment, meaning they use their hip much more than they use their knee. And the force, they offloaded the force on that involved leg. So they weren't using their quad, they were using their trunk and their gluteus maximus. So then the primary thing that people, and this was a study we published a couple of years ago, and what we showed in this one is, what we tried to look at is, okay, what testing are people using? And so we looked at all studies so we had, I think, 209 studies. And we looked at all the studies that measured any component of return to sport testing. And then we calculated percentages and got mean values and everything in standard deviations. And essentially what we found is, since the onset in 1986 of return to sport testing publication, the primary value is time. And the next highest value is strength. But in this strength, the majority of that was manual muscle testing, which I think we would all agree is probably not the way to go. Now, time is very important. And if you talk, this was a really interesting study published by Tim Hewitt. And essentially what they showed is it takes about 2 years to get tissue homeostasis, meaning, the bone bruise to calm down, just the knee joint to go back to its normal level of homeostasis. Now, of course, nobody's going to wait that long. And Heggie Greenham published a very nice study that showed that if you wait 9 months, and the longer you wait after 9 months, the less risk of re-injury. But even that study, the pre to post test probability shift of waiting was a minimal shift. And then if you really look at, in the majority of studies, what is currently in the studies that seems to be the biggest discriminator is it tends to be quad strength. This was a study published by Ingrid Eitzen that showed this was out of the Delaware group, and they compared people that cope without an ACL versus non-copers. And the primary predictor if it was somebody who was going to cope was quad strength. The better the quad strength, the better they coped without an ACL. And this is just one study that I could cite multiple here. And I think this study lays it out really nice here. This is from Ali Golkler's group that shows, and I mean, they looked at different strength measures. They looked at HOP measures. They looked at different patient-reported outcome measures. And across the board, all the things in red at the top these were the percentages that passed. So at 6 months, these are all the percentages of people that passed. At 9 months, these are all the percentages of people that passed. And if you look at the things that people are passing at 6 and 9 months, so above 75% is essentially HOP testing. The things that people are not passing is isokinetic quad and hamstring strength. And then somewhere in between is patient-reported outcome measures. And this is just one of many studies that have shown that the rate limiting factor in many studies seems to be isokinetic strength. And of course, not everybody has isokinetics. And so, but hopefully people will get handheld dynamometers, and there's a bunch of different measures out now, and there's different things you can do. And I'll talk about how some correlations here that you can look at. And so most people will look at what's called limb symmetry index, which means what is the performance of the involved leg compared to the non-involved leg? And then, is it 90%, 80% of the other leg? And the issue there is if somebody has two flat tires, meaning, their overall absolute strength is poor on both legs, then you're just comparing weakness to weakness. And, and so people like Chris Kunze and other people have published some work here that shows that if you look at, especially if you're doing isokinetics, you probably need to look at absolute values normalized values of quad strength. And they suggest getting greater than 3 Newton meters per kilogram at 60 degrees per second. So essentially is what you're measuring is the strength compared of the normalized strength versus comparing left to right leg. And so if both legs are strong, so if a good leg is strong and the limb symmetry index is not good, then that is valuable. But if both legs aren't very absolute strong and the limb symmetry, the comparison side to side are close, I'm not sure that's the way that you want to go. And the nice thing is, if you don't have isokinetics, if you don't have isometrics, this was a nice study by Kevin Lautner that showed that a vertical vertical hop and jump is a very good measure, and it has a strong association with isokinetic testing. And they did it on a force plate, and they did a force mat. There are apps you can get. So there's a Jump 2 app that can measure some of these things too. So there are some clinic friendly things, and I know Dan knows a bunch of these things as well. But I mean, I think we need to go beyond manual muscle testing, and I would suggest at a minimum handheld dynamometry and probably some vertical jump testing. So then when you're doing this, what are the barriers to being successful here? And I think everybody, I mean, if you're a PT, I think the natural first thing is to, well, hopefully not, but I think sometimes the first thing to do is to kind of go to the surgeon or the surgery wasn't successful. Now, of course, that can be the case. And especially if you look at hip arthroscopy, I mean, it's quite honestly, it's exploding. And, there's been surgical rates over a 7-year period that have exceeded hip arthroscopy rates. The growth of hip arthroscopy is exceeded anything else. Subacromial decompression, knee partial meniscectomies, any other surgery, the rates of growth of hip arthroscopy have exploded. The bad thing about, well, there's a few bad things about that, but one thing that I'll focus on here is the level of studies published have not changed. And actually, we've only had one randomized controlled trial. Well, now we've had 3 more published this year, but in this time frame, there was only one. And so we're doing it more and more, but we're measuring it well, less and less, except for just very recently. And this is kind of a big take-home study for me. I think this was before the study came out. Is if you've ever seen hip arthroscopy done, it's very challenging. I mean, every surgery is challenging. But hip arthroscopy especially is very challenging because it requires a lot of traction. You can't see the whole joint. I mean, there's just a lot of challenges. And before this study was published, different surgeons tried to calculate, well, how many surgeries do we need to do for our outcomes to get significantly better and for our complication rates to significantly drop. And prior to this study, it was typically between 30 to 35. There was 2 or 3 studies published anywhere from 20 to 35, meaning you needed to do 20 to 35 to significantly improve your outcomes and decrease your complication rates. And this was a study published in the state of New York. And what it showed is it actually took over 519. And they had, in the entire state of New York, they had 6 surgeons that did that many surgeries. And if you look at how many surgeries are being done, by far the vast majority of surgeries are being done, but at this point, we're being done by people that have done less than 100 surgeries. And in fact, this number is 88% of the total surgeries in the state of New York. And at the time this study was published, 88% of the hip arthroscopies were being performed by people that have done less than 100 surgeries. And if it truly is 519, so it's like hip surgery, you always want to go to somebody that probably specializes. And just working in this arena for almost 20 years now, I mean, I just can't emphasize how important it is to have a hip arthroscopy surgeon that has done a lot of them, because the majority of my caseload is second hip arthroscopies, and second hip arthroscopy patients never do as well as first time around. And so these patients are quite challenging. So is it the surgery? Is it rehab? If you look at, what's interesting, if you look at outcomes post-surgery, this is ACL and this is hip arthroscopy. Both of them show the same thing. Essentially, they show, and it kind of makes sense, but the greatest rate of improvement post-surgery is in hip arthroscopy is 0 to 6 months. Post-ACL is 0 to 1 year, meaning wherever somebody gets at 1 year post-ACL reconstruction in this study, they pretty much don't get any better, at least in that study. Hip arthroscopy, they'll get a little bit better up to about 35, up to 3 years, but it's incremental. And then the other thing that can be complicated, and so, is it the surgery or is it the rehab? The other thing that's complicated, especially in hip arthroscopy, and this is probably both surgeon and PT problem here, is the protocols are all over the place. I mean, they are an absolute nightmare. Now, I think I'm actually a fan of non-homogeneity in protocols because we need to treat the person as an individual, but we need to have some basic science here as well. And if you look at the number of studies that have been published, so I think 3 years ago, they published about hip surgeries. They published the top 50 surgeries or the top 50 articles published. And of those top 50 articles published, only 5% of those top 50 were related to basic science, meaning are we truly seeing, what is hip impingement? When does the hip impinge? What is synovitis? I mean, the basic concepts, and, what puts strain on a labral tear? We need that kind of information to set up these protocols. And I've alluded to the study already, and I talked about this, but, just, PTs that were orthopedic certified that completed the survey, 55% of them didn't do more than use time as a return to sport criteria post ACL. I mean, honestly, I just think that's a complete shame. So, and then I think, I would put myself in this in my past history is I think oftentimes we don't look at return to sport specific movements. We don't specifically look at what does that individual have to go back to, whether it's sport, whether it's activity, work or whatever. And I mean, do we even look at like work to rest ratios? Do we look at them different if they're a wide receiver versus a running back or a quarterback? Do we really look at them in that amount of detail? And I would suggest that we do need to. So we've kind of put some blame on surgery, put some blame on rehab. What about patients? And this information is fascinating to me because this was, to be honest, this is probably an underpowered study, but I think it's interesting nonetheless. So just take these results with a bit of grain of salt. Is what they did in this study is they had these different soccer players, and they looked at compliance, and it was kind of a complicated thing, but it actually did a really nice job. And then they measured, okay, the ones that were compliant, what was their return to sport rate? And the ones that weren't compliant, what was their return to sport rate? And they broke it up into fully compliant, moderately compliant, all the way down to non-compliant. The non-compliant athletes, again, probably underpowered, was a 45% return to sport rate post ACL. The compliant ones were 86% and definitely underpowered. Here's the other interesting thing here as well is the majority of those that were compliant were elite level athletes. So I think there's a lot of things that go into this. The elite level athlete, this is probably their job versus maybe some of these individuals, maybe they've self-selected and said, you know what, it's not that important anymore for me to play. Maybe I'll play pickup games every so often. I myself, I mean, I've self-selected out of some activities due to a back problem. So, I mean, I think people make decisions based on different things versus, just simply on sport. And that's what complicates some of these rates. The other thing, as I've alluded to a little bit, is the expectations. This was a really cool study by Mannion and Franco and Pellizzari. What they did is they took all these people that were going to go to hip arthroscopy. And there's this, can't remember the name of the outcome, but there's an expectation score. And we've done this in studies ourselves. And they have them, I expect to go back to sport, and it's a Likert scale. I expect to have no pain, and it's a Likert scale. So they fill out this expectation score, and then 1 to 2 years out after the surgery is they fill out a fulfillment of expectation score, which is essentially the same questions, just worded, did you return to sport at the same level? And and we found this in our study too, is these expectations were never met. And where the biggest discrepancy or where they were not met at the worst level was related to pain. And actually the biggest thing was related to sport. Most people expected to go back to sport at the same level, and they did, and many of those expectations were not met. And that was in hip arthroscopy. This is Kate Webster and Jillian Feller found the same, thing. They measured expectations prior to surgery, and 91% expected to go back to sport, 84% expect to go back to same level. And if you remember, I talked about the Claire Arden study that showed that only 55% in her study went back to sport. So there's this expectation of going back and performing at the same or similar level, but the majority of the time that doesn't happen. Yet a lot of these people are still satisfied. What about coaches, parents, and even the athletes themselves? These are just some fascinating studies, and these are this was what they asked is they asked coaches, high school athletes, and parents you know, essentially what it came down to is 1/3 to 1/2 of these individuals believe that Tommy John surgery would enhance that athlete's performance. And there have been some reported things where people have actually trying to undergo surgery to improve their performance without having a torn Tommy John. So what about media? And essentially they found the same thing. So this was a different study, but they measured the same thing, was the media, 1/3 to 1/2 expected that people that had Tommy John would come back better than they were prior, and their performance would actually improve. And if you remember what we published is that, I mean, that doesn't happen. I mean, obviously there are cases that do happen. They're much more at the elite level than they are at high school, college, or minor leagues. But in our study, we published that the highest rate was 83%. Now that was definitely underpowered because there's only 5 studies. But even in a major league, it was, again, that's 75%, 3 out of 4. So one of my favorite shows here is, so, I mean, who's at fault? And I think probably like most things, it's like, I don't think fault is the right word, but there's probably a lot of reasons for this. And, it's probably, some of all those things that I've talked about. So are we measuring the right things? Maybe what are some things that we maybe should measure, or are there some things that we're perhaps not measuring? Do we need testing algorithms? Do we need to look at time? I mean, does it need to be 9 months? I mean, do we need to follow the Heggie-Grindum study? Do we need to wait 2 years? I don't think Tim Hewitt would suggest that, but I think that's an interesting point. And do we need to be criterion based? And does it need to be some combination of all of that? Well, there's been some stuff out there for a long time, and Al Vermeil has talked about this for a long time, and Rob can never say his last name, has talked about this, and they talk about these different concepts, and they talk about this, kind of measuring at these different levels, and again, measuring the things that are important and determine success. I think one thing that they've kind of left off, and that I would probably add on it to some degree, is maybe cognitive. And then if you look at, the 2016 consensus statement, they've talked about a lot of these things. And, they talk about, let's do a group of tests, do a test battery. And perhaps the test battery is different. It's probably going to be different for different sports, different athletes, different types of individuals. Choosing open tasks, so less controlled tasks versus strict constraints types of tasks. Include tests that involve reactive decision making. If you look at Dusty Groom's work and some other people's work, where they have to mentally process information at the same time, there's some really interesting data on that end. And then assessing psychological readiness. So ACL, RSI, Tampa kinesiophobia, different kinds of measurement scales that I'll talk about here in just a little bit. And then I think you got to measure internal and external workloads. You have to measure what they're going to go back to. So prior to this study, when it was published, every other study prior to this, so Kate Webster out of Australia developed, and she does a lot of work with Tim Hewitt. She published, she validated what's called the ACL RSI, which is Return to Sport Inventory Index. And essentially what it does is it measures the level of fear and potential catastrophization that somebody has when they're going to go back to sport after an ACL reconstruction. And now we have a hip one, and so there's a couple of different ones out there. The majority of studies all of them prior to this one, all showed that return to sport rates were much lower in individuals that scored poorly on that had high fear, high catastrophization. Now, this study took a little bit different slant to it. What they did is, because I think prior to the study, everybody assumed, well, if they have fear, that means they don't have strong quads, they don't have good movement, they can't jump very well, all those kinds of things. And some of those studies did show that. But this was a very interesting study out of Ireland. What they did is they measured all that stuff, and they found that there did not seem to be an association between strong or weak quads and high or low scores on fear. Meaning, if somebody had weak quads, that didn't necessarily have an association with high fear avoidance. And if they had strong quads, it didn't necessarily mean that they had low fear avoidance. And I mean, this is just one other thing that's fascinating to me. And the other thing is looking at, are we truly measuring what the demands of the sport are? There are a few studies published out there that talk about, deceleration versus acceleration. Deceleration seems to be more prevalent in almost all American sports beside American football. There's, some studies published from High Point University that talk about, how many times soccer players cut and plant. And obviously there's different GPS systems. Unfortunately, all that stuff is held within house and it's not really going to be published. But kind of getting back to the ACL RSI study that showed no difference or no association between quad strength, and return to and fear or catastrophization is like I just think people have different rate limiting factors, and the load on somebody is different things for different people. I mean, some people have high fear avoidance. Some people have weak quads. Some people have social determinants that are the rate limiting factors. Some people have allostatic load types of issues. Some people's grit is lower than other people's grit. And this kind of gets into some stuff that we've been dabbling in just a little bit, is what's called phenotyping. And it's not necessarily genetic phenotyping, but like we looked at this in some of our our hip impingement patients. And we were underpowered, so we didn't publish it. But in my opinion, I think there's a couple of different groups of hip impingement patients. And if you look at the studies that are published, Dan Ron has published a couple of studies, and it shows there's been 2 or 3 studies that look at people that have had pain for 2 or 3 years, have hip surgery, and then measure their outcomes. Those patients' mental comorbidities actually exacerbate after hip surgery. Now, of course, the hip surgery doesn't cause those mental comorbidities. They just influence them. They exacerbate them. So, and so, I mean, I don't know anything about Adrian Peterson's rehab. I don't know anything about Derrick Rose's rehab, but I mean, it's just fascinating to me how you can get different elite level athletes. And obviously there's multiple different measures here, but like, I think phenotype, I mean, if you look at low back pain, phenotyping, meaning, somebody is a hip, I mean, if we look at hip impingement, somebody is truly a hip impingement patient. Somebody is a mental comorbidity type of patient. Somebody is, and it depends on the sport, it depends on all those kinds of things. And I think the more information we have ahead of time, and if we measure those people and we know they score high on OSPRO or whatever measure we use, like, we should rehab them differently. And we should take those measures and adjust our rehab accordingly. Because people are, I mean, they're going to have these different phenotypical presentations. And, this is just an awesome quote by Terry Grindstaff. And he just, this was a Twitter conversation a long time ago. And on there, they were just kind of going, this was when fear avoidance and ACL RSI was really, really big. And the previous person had just kind of quoted how big of an issue it was. And it just, as everything on social media, the thread just kind of got out of control. And Terry just kind of brought everything back to normal and just said, you know what, if your car's not working, and because, something's wrong, the brakes on the car aren't working, and you're scared to drive the car and you're normal, it's, you don't need counseling, you need to fix the car. If your car is not mechanically sound, or if your car is mechanically sound, I'm sorry, but then you're still fearful, okay, that's probably a time to get some psychosocial help. Meaning, what is the limiting variable for not being successful? So, and I mean, I love that quote. So I'm sorry I butchered it. So kind of in conclusion here is, returning to sport is, even in elite sports environments, the re-injury rate is probably 20 to 25%, and in an Italian study it was 40%. And it tends to be much more, or a higher risk of injuring the ipsilateral or non-injured, non-surgical leg. If you look at young individuals, it's going to be about 1 to 4 that meet symmetrical function of their quads after ACL reconstruction. So 25% actually have strong performance. And it kind of gets at Terry's quote is, if your quads aren't there, it doesn't, yeah, fear might be an issue, but you need to get the quads back. And if the quads are normal and they have fear, then obviously the fear type of rehab takes a primary importance. And then so the overall secondary rate is about 15%, but again, 20 to 25% in young individuals, and as high as 40% in that Italian study. And then, we just aren't doing a good job of testing and in non-published studies. We look at that Greenberg study and the Berge study. We're primarily looking at time. When we test, we typically, the majority of individuals, when we test them, especially on isoconnect types of testing, in this study, they found that one out of 6 actually met the criteria. And then in some instances, even if they pass that test, what does it actually mean? Because in our study, we showed no association. And then we need to make sure that our patients are ready, if the strength isn't restored. Returning to level 1 sports at post-ACL in young females has a 4-fold increase in re-injury at 2 years, 6-fold increase compared to males. We're probably not measuring everything that needs to be measured, and then perhaps even looking at things like I talked about it, is phenotypes. All right, thank you.